So today what we're planning on doing is giving you an overview, and also we want to get your input on the episode of care for cholecystectomy. So we're going to be doing a brief overview of the whole episode of care payment design, which most of you are now familiar with, discuss cholecystectomy and look over some of the data and the framework and some of the opportunities for portraying this episode in terms of report cards. I want to go to the next slide. We've talked in the past about how healthcare, Arkansas has a fairly difficult health status of its patients. Some of that has to do with the socioeconomics of the state, the education of the state, a variety of other issues. And so we have a lot of challenges in maintaining the healthcare system. And as we have said in other meetings, what we have is a system that is more and more difficult to continuing to raise premiums, taxes, co-pays on patients, employers, or the taxpayer. So we have to look at different ways of incentivizing how we deliver health care. So very often what we have now in health care is we pay for events and not outcomes, and we're trying to shift in a multi-payer approach to paying for outcomes. So on the next slide, what we're doing is looking at how we restructure how healthcare can be delivered, medical homes, health homes, episodes of care, use of health information technology, rethinking the workforce. It's really a comprehensive approach that we're working with the governor, the Surgeon General, and others. And this is just today's episode on cholecystectomy is one component of that.
When this all started over a year ago, the governor's office made contact with our CEO and had a discussion about the projections for the Medicaid budget going forward. And the projections then were that beginning in fiscal 2013, which begins next July, it was projected that Medicaid would lose $200 million in that fiscal year starting in July. I think those numbers have fluctuated a bit, but the last one I heard was a little bit higher than that even. And because the governor also knew that private insurance premiums were getting to the point where people were unable to afford or already had dropped their coverage, he asked to see if we had anything in common as far as being able to work together to see if we could find a way not just to pay less, but to pay better. And I think this is what this initiative is all about, trying to find a way to pay better so that at the end of the day, the only tool in the kit is not an axe, and the only thing that we can do to hold down cost is to just reduce unit price reimbursement to providers. So thus that's why we're here today. Andy Allison, the Medicaid director, when he's here usually does this slide the best, but what this slide is meant to portray is that there are several options that the payers have at their disposal to try to reduce the amount of payment. You can see the four down there at the bottom that we'd rather not do, and that is reduce payment levels, as I said, pass growing costs on the consumers. On the private side, we can increase deductibles and increase out-of-pocket and things like that. More and more, those expenses are becoming uncollectible by the delivery system, and so as we do that, not only is it a further burden on consumers, but a lot of times it's a further burden on providers as well. Medicaid really is limited in the amount of cost sharing they can do with beneficiaries, but certainly the other option for Medicaid is to raise taxes on all Arkansans. Intensify payer intervention in decisions through managed care or elimination of expensive services. Payers can go ahead and try to put in more mother may I kinds of things like pre-certification and things like that. We'd rather not do that. It's a pain for providers. It's also very difficult to administer for us. And then one of the other options is to eliminate coverage for expensive services or just quit covering as many people as we do currently. And we don't believe any of those are real good, positive approaches to this. So what we want to do is to try to transition to that payment system that rewards value and health outcomes, in other words, pay better as opposed to just paying less. Next slide, please. So the principles of this initiative are that it be patient-centered. There have been many comments about the fact that just because of the way it's constructed and the incentives inherent in the system, that we have a very non-patient focused, very reactive delivery system. And what we want to try to do is to change the incentives to create a more proactive approach to keeping people healthy and managing disease. I want to make sure that things are clinically appropriate. There's a lot of variation that happens out there, and whether it be variation in quality or variation in cost, really the point of this program is to try to identify that variation, drill down and find out what the source of that variation is, work together to determine whether that variation is justifiable, and where it's not, try to eliminate it. And it's got to be practical. It can't be incredibly complex. It can't knock down the whole house of cards and require us to build it back up again. And it's also got to be data-based, so the design decisions have to be based on sound data, which we believe we have better data than we've had in a long time or ever before. So next slide. This all began over a year ago when we started working on the first set of episodes, and we'll go over what those are. But initially, to introduce the concept of episode-based payments, we had a lot of work groups that involved over 500 providers, patients, family members, to try to get as much input as we could. 21 public work group meetings on the first wave of episodes, 23 months of research, and updates with as many of the key constituencies as far as association, whether it be the Hospital Association, the Medical Society, Arkansas Waiver Association, what have you. We try to include as many of those as possible, and we'll continue to do that because we believe that an important part of the education and the communication in this is the use of those organizations. So we'll continue to try to keep those lines of communication open. Next slide. So let's get into a little bit of the episode model overview and exactly what the nuts and bolts of this methodology is. So first of all, the episode-based model is designed to reward team-based care. It's designed to create incentives that make it make more sense for providers who are treating the same patient for the same illness to collaborate with one another. I'm sure that happens some today, but the incentives in the system are certainly not designed to compel providers that are treating the same patient to coordinate. So the goal is to do that. Accountability. Those of you who have been exposed to this methodology before know that in the episode we choose a quarterback or a principal accountable provider who's in the best position to make decisions, is in the best decision to decide other players on the virtual care team, and really has a very relevant component of the cost that he actually provides services for. And we'll cover that a little bit more detail later. But then the incentives for high-quality, cost-efficient care rewarded beyond current reimbursement. And we'll talk a little bit about the fact that this does not disrupt cash flow. The idea behind this, for those of you who were involved in some of the initial work groups, we had initially proposed prospective bundled payments, which simply means that we would decide an amount of money that should be sufficient to cover an episode of care. We would choose one provider, we would provide that amount of money to that provider, and then it would be up to that provider to parse the payments out to the rest of the providers on that virtual care team. Very quickly, the provider community made us aware that there is neither the financial integration nor the business process integration that currently exists in the system to allow that to work very well without significant disruption and a long lead time as far as putting that into place. So we got back together and said, well, how can we do this so that we don't upset the apple cart so much, but we can accomplish the same thing? And so we'll talk a little bit about the fact that this is still really based on a fee-for-service cash flow, but then it is reconciled as far as the average cost of an episode so that there's not significant disruption in the way cash flow works today. Next slide, please. So this is how it works. The patient receives and the provider delivers care just as they do today. Patients select their providers. The providers submit claims on the same claim forms using the same coding, so there's no disruption. The payers reimburse for all services just as they do today. The key here is, we had a lot of speculation at the beginning that this was all going to start out with all of the payers going to the lowest common denominator. In other words, we were all going to start paying at Medicaid rates. Let me assure you that that is not the case. We don't intend, we don't anticipate, and we hope we don't have to reduce unit price reimbursement, because if we're effective at this, we won't have to do that. Next slide. So what happens is, at the end of what we call a performance period, which is generally a calendar year's time or a 12-month period of time, we'll go back and look retrospectively at the cost of episodes that are eligible for this payment initiative. And as you'll hear in a little bit, we'll set target levels of cost that are based on not on the best practices in California, New York, in England, or anywhere else around the world. We're looking at better practices that currently exist in this state and saying, why can't we identify those better performers and find out, for good quality care, that there is variation in cost. What's driving that variation in cost? Share that information across the system. Allow others to be able to implement those kinds of things that are working better, and if we achieve savings, actually share those savings back with the people who are responsible for creating those. I also get a question a lot about, all this work is just to benefit the insurer. If any of you know much about the Affordable Care Act, you know that there is a provision in the ACA called the minimum medical loss ratio, which basically says that if an insurer pays out less than a predetermined percentage of the premium they take in, 80% for large group, 85% for large group, 80% for small group and individuals, if the loss ratio is better than that, in other words, if the insurer didn't pay out that much as a percentage of the premium, those premiums are to be rebated back to the premium paying customer. And while they would appreciate that very much, and it is a good way, to regulate and make sure insurers keep their premiums competitive, we think that there may be more benefit in using that money to pay out in incentives to providers as opposed to paying it to members who, number one, might not know why they got it. They appreciate the fact that they did, but it probably won't change any behaviors of those people that are seeking care. So what we're trying to do is to keep the money within the system to pay better, as we talked about before. So at the end of the period, we review the claims for the principal accountable provider, and we calculate the average cost per episode. We're not going to settle these on an episode-by-episode basis. We look at the includable episode over a year's period of time, and then compare the cost for that principal accountable provider, the average cost, to the target cost that Bill will talk about a little bit more in a second. So yes, the cases are still going to vary because patients vary a little bit, but when you look at averages, from a statistical perspective, a 12-month period of time with as many episodes as will be included here, that's a reasonable way to look at it, we believe. So based on the results, providers, if they're effective in holding costs down below the predetermined targets, will share a portion of the savings that are created. Those that are at the highest end, that are above what's called the acceptable level, will be asked to share in a portion of those excess costs. And then there's a middle range where many providers are going to be in, at least initially, where it's considered acceptable and the fee-for-service payment that is made will stand. And so it's an evolutionary process. I think you'll see that we have taken a position of being rather conservative. We're not trying to hurt anybody in this, but we're trying to educate ourselves and the delivery system that variation does exist, that there is work to be done as far as identifying the source of that variation and trying to eliminate that which is unjustifiable.